torturing data long enough and it will confess. There are several problems with that, of course. Firstly, if it dies in the process. And secondly, if it does confess, is the confession true? Middle Ages, they used to have dungeons and devilish apparatus and a few political enemies. Now we have cloud platforms, visualizations and data, and it's more about consensual S&M than I think it is about killing anybody. St Andrews, large private hospital, quite an acute services. It's got cardiac surgery, day procedure suites, 9 theatres, robots, ED departments, ICUs. So it's got a broad, complex care profile as an acute hospital, and it's won the Baxter Health Award twice and the ACH Award for measurement, quality measurement, and is a national demonstration site for us. So it has a combination of both intense curiosity about money, but also about quality. We put, until last year, all of our 650 indicator sets, which are basically static Excel track and train graphs, into a performance management system, and we use that system for making decisions on many, many aspects of the hospital's operation. So it's a core data set for us. And we've now gone and added even more data to it because we have a cloud, and then even pulling the finance data in as well. So now we're able to manipulate large data sets, and I'll show you some ways of doing that. Now, you've all seen these things, the caterpillar plot, risk-adjusted mortality. There's another one, the funnel plot, okay? Everybody familiar with these? Yeah. And they're adjusted for the size of the hospitals and your expected and your actual mortality rates. And you can see there that there are ones above the line and ones below the line. So the ones above the line seem to have too many deaths as against their prediction, and ones below seem to have fewer. So we can choose one. Okay, now this is real data. What we've done is just try to torture the data for you, okay? So what does the HSMR look like? Let's pull it apart. You can see down the left, there's the major diagnostic categories, such as the E code, respiratory code, F's cardiac, G gastrointestinal. And then further over, you can see now how many medical cases, surgical cases, what the partitions are, what groups of risk profiles they're in. And then further over, you can see the principal diagnoses that make up those groups. And then further over to the right, you can see what we've created is a profile of the comorbidities within the patient data set. Predicted mortality risk, what sort of risk profile are you managing? And then a very interesting line there, the third one along in the middle there, was difference from expected, and you have to take my word for it if you can't see it on the screen, but it's all negative, which basically means that the expected and the observed is always better than the expected, so we've got a negative report against the HSMR, so that's why the hospital sits underneath the 100, because it's got less than expected. And that's in the bottom right-hand corner, there's that green line, which is in the negative zone. So we've tried to pull this data apart, look at its characteristics, and then try and display that. Let's go into patient deaths. So if you just open up that, then you can start to see the separations and the deaths, and then you can look at the deaths. Comorbidity index, predicted mortality risk, age, very interesting. Obviously, the deaths are in the higher age groups. And there's the length of stay. So again, you can pull it apart by sub-analysing sections of it. So you start with a figure, you get into the data, and then you can start to have a look. Let's look at respiratory cases. What does that look like? They're quite well represented. Okay, you can see there's 2 clusters of comorbidity index there, predicted mortality risk, age again, quite old, length of stay. So it's possible using these analytical techniques now to actually look at your own data, which you should be able to produce yourselves. It is technically quite easy to do that now. And then you can pull them apart and see what it is you think is representing the drivers of that. So that's torturing HSMS data. What else could you do? What else could you do? Well, maybe what we could do is to say, well, what are the top 3 diagnoses that are that driving this? You can see I'm doing this with no hands. Okay, right? So you can then cut the data in a different way, and you can look at then the diagnoses that make up the top 3. And then get your difference from expected and predicted risk. So you can go on like this, all right? Just a demonstration of what is possible with the analytics. Now, next question. Well, okay, let's think about this. What, at an organizational level, what might be involved in driving mortality? What might that be? Okay, Staph aureus bacteremia. So when you're analyzing your performance, even though it might look good, it may be extremely good in some areas and very bad in others, right? But you still may have a nice HSMR nonetheless, but it's mixed. But let's just look at the organization's drivers of mortality, see what you've got. Okay, so we've got Staph aureus bacteremia rates that are very low. So falls against closed head injury, that's the rate of falls. I know that's underneath the 20th centile for the ACHS, so that's low. So there's nothing here. VRE burden, as you can see, we all went through this extraordinary VRE epidemic, but virtually no cross-infection, which is good, so nothing there. Return to operating theatre, not risk adjusted, but that's entirely possible to do that as well. That's just a set rate, but you can adjust if you so wish. A little bit more technically complicated, but possible. Stable, what have we got there? Pulmonary embolism, stable, dropping, both medical and surgical. PICC line infections, had a very poor period of PICC line infections about 10 years ago. We virtually have none now. And you can see, you can also annotate charts and see what's happened. So if something was going wrong, you might be able to work out why. If something's going well, you work out why. So we're torturing now the subdata. So we're trying to reference an HSMR, then reference it down into this subdata, which sits in all the ACHS indicators, of which we have all of the ACH indicators and others. We've got about 650 there. Okay. What next? Okay, now we might say, let's have a look at the data. People die, you go through an audit, the audit is electronic. So let's see what the electronic audit says of the deaths. All right. We can look at those, and then we can look at categories like unexpected death or anticipated death or possibly preventable death, and then you can start to cut and dice them. You can then slice those by location, so you can see where it's happening. You can slice it by Met criteria, were the Met criteria triggered and for what purpose? Not a lot there. Most people didn't have a Met. Systems issues, what are you seeing in the data there? Failure to monitor renal functions there, otherwise not a lot. You can torture it a bit further. Let's have a look at individual issues. What do we see there? Okay, there's a few around failure to monitor, one around failure to monitor renal function, prescribing inadequate, but most no issues. So you can just torture and torture away here, just looking for patterns, systems issues, failure to monitor renal function. Okay. And then you might want to open up and look at some of those individual cases to see, well, exactly what it was. It's acute renal failure on the left there, that's the cluster. We can open up those cases and have a look. So, I mean, again, you can just torture this data, try and make sense of the patterns that you're seeing on your HSMR, linking it back through the hospital drivers of mortality, then looking at the actual individual cases that are being addressed clinically to see what the clinicians think about that data. Right? This is the beauty of the interactive platforms. And then you can drill down into look at those. And we've changed the names to protect the guilty there. Okay. Now, what else could you do? How else might you torture data on the performance of your organisation? Now, this is a map of Victoria. This graphic works for Victoria because Victoria is long and flat, so you can put it on. But Western Australia we can't do because we can't fit it on the chart. Okay. Now, this is a program that isn't actually backed by the data, but the program is available, and but for having the data plugged into it correctly, it would operate like this. So just to show you what's possible with the analytics, let's say unplanned readmissions against age. So you can start to look at, as you move the cohorts through, where people are starting to be readmitted from. Okay? So there's visualizations. This would I don't know how you could otherwise do this. You wouldn't get an insight into these sort of processes and where people are coming from and moving to without these analytics. But it may be very important in the risk model about, what it is your population, how dispersed they are, and what it is that's happening to them, and where they are, and how did you discharge them, and then what happened when they came back, and where did they come from. So these are tools, again, for helping there. What would happen, though, if you wanted to look at, say, the flow through the hospital? What could you do there? Is there another analytic? That's a leading question, of course, because there is, right? And the admission flow map. So you can now map over your organisation where people are coming from, where they're moving to, through, and whether they died or not, and where they came from when they did die. Maybe that's a useful way of torturing the data further. And that's the flow of patients through an organisation. Again, that's not real data, although the numbers are right and the proportions are right. That's just to show that the technology exists to do this, and if we were to plug in the actual data and to plug in the hospitals, that you would get to see the real graphic, the real visualization of that. But it's again, you're now able to torture data like this in a different way. Now, how else could you look at this? Now, this has been so far about a single organisation, right? But what if you could see lots of organisations? What if you could see lots of organisations by very specific things, which you can with the cloud because it'll take any amount of data and crunch it for you in nanoseconds and give it to you in a graphic. So let's have a look at respiratory tract infection E62A. Let's have a look at it by average DRG cost. Let's have a look at it by the output, say mortality. All right, and the size that we're going to deal with is occupied bed days. So we'll have a look at the graphics, see what it looks like. This is a fascinating graphic. Okay, now just let you accustom yourself to that. You can see on the chart that down the left-hand side is the vertical line is cost for the DRG. Right, that's cost at the organisation's level, at the provider level that the dots are. So those provider level dots have those costs. Right? And you can see at the top there's some very expensive smaller service there, technical efficiencies, scoring. Okay, very expensive, but quite good because their mortality is low down the left-hand end of the graph. Okay, and down the right-hand end of the graph, you've got some technically look very cheap services, but very dangerous. And then down the left-hand corner, you've got two hospitals. Okay, which are ticking away very nicely, about minus 20% to the payment price, right? And a little bit less than that with a higher quality, again, of 3%. Now, if you just click on the cross there, That may be one of you. You're currently operating above your reimbursement, and you're about technically efficient, 50% technically efficient, TE 0.57. So you would want to move down to that frontier. This is a graphic about value. This is the graphic about the interactive relationship between cost and quality. And these graphics can be created in real time, continuous real time, for large groups of hospitals or services or providers doing the DRG. This enables you to see in real time how everybody is moving in regard to relative value. And it makes a very important point in this, that it's possible to operate extremely high quality services, this is real data, extremely high quality services at less than reimbursement. Now this whole questions we listened to earlier about cost and quality, it's true, you can get extremely good quality for less than the reimbursement, because the reimbursement is not a national efficient price in the sense at all in public sector, it's a national average price, got nothing to do with efficiency. If you do take an efficient view of it, though, you can see how possible it is. This is a form of research. You can change what the units are doing, the services are doing in a deliberate way, and you'll see how they're moving against each other. So this is an extremely rapid evidence to practice research tool for management purposes. And that's essentially what the essence of the company is about, is creating new management processes to improve cost and quality. Just final thoughts. We use HSMR, it's effective for high-level signal detection. I think it's a good thing. David will talk more about this. He's a real expert in this area. It's, however, a multifaceted problem, and it has drivers which are in the models and it has drivers which are not in the models. And different ways of visualizing it, you may well be able to create a much better model, or create a model for your own services that actually create your own HSMRs depending on your variables within your models. It's possible to do that. And you can use advanced analytic tools to pull the data apart and torture it, and then look at different ways about how it might be moving, and then link it to existing systems, and then looking at it through value, through bringing the cost in as well as the quality, and managing those things in real time in large data sets. We've already got enough data, it's really now, and enough capacity in the clouds. It's really about thinking about how you want to see it, and that's what we spend a lot of time on. Even this thing about new machine learning, it is possible to actually automate the algorithms, and then the algorithms actually learn about what happened and then change the algorithms as you go. This is not science fiction, it's available. I reckon we could probably do that, in a few months we could have a system like that running, and we'll try. The other thing, of course, is it needs to be integrated as an improvement approach into the care processes within a culture of excellence. And the graphics and the visualizations and the data capacities which currently exist are enablers for you to do that. It is possible using these displays to get a very, very good handle on cost and quality, and to bridge that gap between clinicians and administrators about cost reduction versus quality. It is possible now to fill that middle space in with these sort of displays. Thank you.
Well, thank you very much. I mean, that's a particularly fascinating presentation for me from 2 points of view. I've known Chris for many years, and I can remember really the origins of this system a number of years ago in a place we both worked at, and it's fascinating to see its maturity. I guess Chris is in a way, I mean, we've got these two talks slightly the wrong way around, because I think Chris has helped answer a how question. I think what I'm going to talk about is why you'd want to do this and what are the drivers to doing it, and what are some of the reassurances, if you like, that I can offer people who are interested in pursuing these or related paths. But, because I'm a kind of interested in culture, I always like to start with a quote, and this is from James Clerk Maxwell, the great 19th century physicist, who said the real reward for the labour of careful measurement is not greater accuracy, but the discovery of new fields of research and the development of new scientific ideas. And I think that's very well illustrated by what Chris is doing, that in healthcare, we can get over-concerned with accuracy. But our real task in measurement is to understand and drive our understanding further, and that is, in the end, the net reward, and that's what I'm going to talk about. And Chris talked about hospital mortality. It's a very good example because of the one outcome measure that we are confident about. It is only whether we leave hospital dead or alive. There is no equivocation in that. Interestingly, the measurement and publication of hospital mortality, which in a way, from a consumer point of view, represents still a very non-trivial matter. This is non-trivial to you as a consumer. It's only been controversial for about 120 years now. And this photograph, I don't know if anybody recognizes it, but it is of Florence Nightingale, who was actually a very fine statistician, not allowed to join the Royal Statistical Society because she was a woman, of course, but nevertheless a fine statistician who encouraged the publication of relative hospital mortalities in London in the 19th century. And when you read the papers and the critiques of that publication, you are brought slap bang into the latter part of the 20th and the early 21st century. Very little changes in relation to concerns about accuracy and reputation and so on. And I'm going to preface this talk by telling you a small story. I'm avoiding the word conversation because I'm finding that we're in a kind of conversation excess period, and I'm going to try to avoid the use of the word space, because when I hear talks with the word conversation and space together, I always get a bit nervous. But I'm going to tell you a little story, and it's about career-limiting opportunities for clinical epidemiologists, of which I am now deeply familiar. So in the early part of the 2000s, our clinical epidemiology unit was given a very substantial sum of money by the Department of Health, I think actually because they'd had some quality funds from the Commonwealth that they hadn't expended in time. So they gave us it as a kind of bolus of money, and they said, what we want you to do is to create some measures of hospital quality and safety. And if you could just do it by the end of the financial year, that would be very helpful. And we naively said, oh yeah, we can do that. And because we're clever people, we give it a go, read some of the literature, and we decided that we would cut our teeth on our measurement process by starting with hospital mortality and hospital readmissions. And to be honest, we were completely naive. We had made the assumption that basically hospitals would be pretty similar. That you'd be, these are public hospitals, you'd be likely to be at pretty similar risk for dying during the course of hospital care, whichever public hospital you went to in South Australia. And as I say, we did a whole set of analyses. We undertook we recognized that patients weren't at equal risk for a variety of reasons, and I'll come back to it. We adjusted hospital mortality rates for relative risks of the patient concerned, and then we looked at the data, and I remember showing it to a number of very prominent South Australians, and I was asked to present it only at the dead of night and in secret from now on. But nevertheless, I thought it was important to go and present this information, and we had a kind of little Trek system. We ran down all the major hospitals in South Australia and described the data to them, to the clinicians, to the managers, to the boards, everywhere we could find. Now, I know these are rather difficult to see, but I hope you can see there's a graphic, and you can see a red line. Can you see that red line? That red line is the relative mortality of a large institution in South Australia. It had been running at a 30 to 40% excess mortality for about the previous 10 years. This was a stable observation. And this period here, this is the green period, when we noticed that. To be honest, this was an absolute surprise to us. There is a period from here to here, over a 3-year period, when we kept telling them that there was a problem. And it was a fascinating experience. There is a phrase that I've come to associate with great risk, which is when a clinician puts his hand on his heart and says, I can see that you have done everything possible to adjust your analysis scientifically, you're showing me that the mortality in my unit is greater than I would expect, but in my heart of hearts, I know that my patients are more difficult than everybody else's. And the moment I hear the word heart of heart, my heart sinks at that moment. But then this is the career-limiting moment. This is an interesting point. After 3 years of persistent trying, I was getting nowhere. And I took it upon myself to write a letter. The kind of letter that you write to senior officials that says, once you have received this letter, you can never say that you did not know. You can never say that you did not know. So I wrote one of these letters, creating a bit of consternation, had various meetings, and at that point, a senior group of staff in that hospital said, we know you're talking rubbish, David. We know it can't be true because we are a great hospital with fine human beings, but let's pretend that what you're saying is accurate. Let us just pretend that it's accurate. And they formed a powerful senior group of clinicians from across the institution and started acting as though this were true. And this is the extraordinary result. Over the next 3 years, the mortality of that hospital fell by about 40%. We've done a lengthy series of analyses that demonstrated this was a real fall. It wasn't due to gaming, it wasn't due to change in case mix, it wasn't due to anything else, it was due to making the hospital safer. There was a genuine excess mortality due to processes of care in an institution that was proud of its own capacity. And I have to tell you, my career has never recovered from this particular observation. And the really interesting thing about that is you would think a hospital that had reduced its mortality by 40% would be proud of that. But you have never heard this story until today. This has never been published. This has never been described. This has never been put in the public domain, not because it's not a good news story, but because people are wary of their reputations. This is the world that we live in. Is it rational? I don't know. Is it true? Absolutely. So this has given me a very powerful interest in the issue of the measurement of mortality, and I was delighted to hear the proposition that at some point we would make all this public, because I think that probably would have an impact on things. Okay, let us go back to work that has continued on this problem of hospital mortality. They all have the same characteristic, measurements of mortality, and essentially all safety measurements that are adjusted in any way have the same characteristic. That you observe something, but you try to work out what would have happened. You estimate what might have happened under a variety of circumstances, and you compare what happened to what might have happened or what have been estimated, and if your observed numbers are greater than you would have estimated in a variety of ways, that's a bad outcome, and if they're less, it's a good outcome. And, you know, I'm not going to, you can get very interested in the mathematics of this, but basically what you do for this and every other quality measure where you make estimates, you create a kind of standard hospital. And in the case of the measurements of hospital standardized mortality in use in Australia, that is all Australian hospitals. Every single patient treated in a hospital in Australia is included in the standard hospital. You assess the impact of patient-level factors on outcomes, and then you use advanced statistical techniques to identify things that are important, and then you make relevant adjustments that mirror things that increase and decrease that. You apply that back to hospitals, and you create an estimated number of deaths. Why have I gone on about that? Because estimates are not facts. They are not facts. They don't tell you anything factual. They are mathematical predictions. And like all predictions, are subject to error. So when you read a paper that says, you know, Hospital X kills 20 more people than you'd expect, that is as inevitable in healthcare sensationalized reporting. These are mathematical estimates. People complain about that. Although it's quite noteworthy that they don't complain when their obscure piece of scientific research is defined as a breakthrough in cancer treatment. They don't say that's nonsense because it's 20 years' time and we've no idea. They don't complain about good news, but people don't like bad news, and that's human nature, I think. But there are statistical measures, and if you change the inputs, you'll change the outputs. I mean, there's nothing magic about that. They're mathematics. And if you change what the mathematical characteristics are and the modeling techniques, you get different outcomes. That's inevitable when you are using advanced maths. For hospital statistical standardized mortality ratios, they're based on administrative data. There is no extra burden on hospitals from generating that information. And that's useful because there isn't actually any indication that the addition of information from laboratory or other diagnostic services increases the precision of estimates. Administrative data seems to work all right. People are very concerned about changes to morbidity, comorbidity. They're very, very preoccupied with the accuracy with which hospitals code data. Frankly, for measuring hospital population mortality, it's relatively irrelevant because the impact of age is so great on mortality outcomes that everything else, apart maybe from whether you're an emergency or an elective admission, every other influence is modest in comparison to the impact of age. And age is almost certainly accurately recorded in administrative data. Why is this so? Why does this kind of rather crude statement so? Because, of course, it's a convenient fiction that healthcare saves lives. That's just a figure of speech, isn't it? Death is inevitable for all of us. All that healthcare can do is bring forward the time of death, delay it, or have no impact. That's all we can ever do. And the limitations of biomedical science means that there is inherent uncertainty about what we do. And thank heavens for that. Because just imagine, Dr. Farmer comes into the Flinders Medical Centre and we run an algorithm from the cloud and it says, Chris, you're not looking good here, you're not going to make much of an impact from care. I don't think we'll bother to treat you because our prediction is that you'll die anyway. God help us if that ever becomes the case. There is uncertainty around whether healthcare delays, impedes or advances the time of death, and that is part of our inherent uncertainty in what we do, and long may that be the case, because otherwise, I mean, we would abandon efforts to treat, which in some cases would clearly be of great value. And the other problem is that we don't have gold standards in what we're doing. We don't know what an optimally safe hospital looks like. I mean, the faintest idea what an optimally safe hospital is. We've never found one, we don't know it, we've no idea. And all of these measures need to be, in the end, adjusted against a gold standard institution, and there are none. We don't know what the mortality or any other outcomes would be in an optimally safe hospital because we've never found one. So what we do is we merge everything together and we look at kind of standard practice which embeds the very substantial adverse event risks that we already know exist. We, as previously said, we have no single measure of the quality of care, maybe because we haven't found it or it doesn't exist or there is no unitary construct of quality, which I think is actually the case. So these are we need to take these limitations into account. So how do we make sense of it all? Because, we're looking at advanced maths, we're looking at uncertainty. How do we make sense of all this? What do we do? What is it that we can use? What are the limits of what we can know as biostatisticians that we can tell people? And here we have a very simple formulation. We can say that when there is uncertainty and lack of clarity about a measure, there is a rise and fall of chance. Common cause variation, as it was known by Schuart and Deming. These are ideas that we've only had in the quality community for about 100 years now. So healthcare has been rather slow to adapt these, but we're kind of catching up. Common cause variation is variation due to the rise and fall of chance. Special cause variation is something has happened so substantial that it can't be due to chance alone. And to employ those, as Chris showed you, in our view, the only way to do this properly is to use something called a funnel plot, which makes use of a variety of statistical properties to give you a picture which has this characteristic, that you see these two lines here. The picture is adapted by the fact that big hospitals, their measurements are more precise because you have larger numbers than small hospitals. This is an array of which this is the expected death. The distance between these two lines here are the limits of what is likely to have occurred by chance. If you fall somewhere between these two lines, you are in an institution whose results are essentially, relative to each other, attributable to the rise and fall of chance. If you're in one of these institutions, above or below this line, then it is likely that you cannot dismiss the results in your institution due to chance alone. That in the hospital that I described initially, their results were actually somewhere out there, and they spent 3 years dismissing them because we'd made measurement errors. Anyway, we can't have got it wrong because we're a fine group of human beings, and so on and so forth. They dismissed them out of hand, and when they finally took them seriously, 40% of their deaths were demonstrably preventable because they actually prevented them over that period of time. But when we look at a plot like this, does not tell us why an institution has an excess mortality. It merely tells us that it does. For those kinds of things, we need the kind of more detailed analysis of the kind of things that Chris is talking about. But what we do know when we look at this is that the number of institutions whose results are excessive is greater than we would expect if chance alone was at play here. In other words, there are factors that make some institutions safer than others, and they are not due to chance. What they are due to, we've no idea. We need to find that out. It's a field of study that we proceed with, but it's a field of study that I think we need to take seriously. So how do we respond to it? Homeostasis or gaming? Homeostasis assumes that the feedback of results will lead to remedial action. Gaming says, actually, we're going to simulate improvement, but we're not going to actually change anything. We're going to make the figures look better without changing the outcome. How do we minimize? Because gaming really it's fascinating to sit in a room with grown adults, in a setting such as healthcare, where patients really are influenced by the outcome, and hear them seriously discuss how we can manipulate the data to make things look better. In a way, we ought to be ashamed of ourselves when we do that. But, human nature being what it is, that's what people do. But how can we minimize gaming? Well, we need things that we believe in, that have face and construct validity. And I've tried to show you in a variety of ways that I think of the outcome measurements that we have available, mortality is one of the ones that are reasonable, that we can have some confidence in. We need to audit them with rigor and really unpredictably. There's nothing wrong with accreditation. I'm a strong supporter of it. But go to any industry that wasn't to do with life and death. It was merely something trivial like a car or biosecurity or, whether your watch works, and they'd laugh at the proposition that you're going to give people 6 months' notice of when you're coming to check up on the fidelity with what they do. It is a practice that ceased everywhere else in the industrial world about 50 years ago. It's fascinating. Oh, God, it's difficult, isn't it? Oh, grindingly, second by second, we try to drag healthcare into at least the 20th century against enormous resistance. Thank God it's not life and death that we're dealing with, Dear, oh dear, fascinating. But what we do know is that, as we've talked about earlier, when you activate competitive forces and the risk of reputational damage, suddenly people start taking the work seriously. And that really puts us in a dilemma, because quality and safety indicators may be most effective when there is a risk of reputational damage. When I can read about my hospital and when the health scope, despite our concern not to tread on the toes of doctors' modalities, when the health scope reads that it kills, 5,000 patients a year extra every year, and that's a terrible thing, it's going to take that damage to its reputation seriously because it's in business. So the risk of reputational damage clearly is a powerful driver for improvement. It's also a very powerful driver for gaming. You know, the greater the risk, the more likely people will be to want to game them. The greater the risk, the more effective the process will be. And so we go on round and round in a very difficult kind of dance to try to provide some fidelity in the process, to which I have no easy answer, except for one of the things is unpredictable auditing. That would be a very good start. Okay, so where do we end? And there may be, this is a very brief trip round a very complicated process. At the end of the day, I think this is actually what all safety measures really need to do. And we're talking here about mortality, but I think they apply to all safety and quality measures. A high HSMR, a high readmission rate, a high unexpected return to theatre rate, a high Staph aureus bacteremia rate, a high VRE rate, a high HSMR is a trigger to ask hard questions. I mean, it's a great phrase. These are hard questions. They're painful. They're hard partly because most of us, I would say 99% of people who work in hospitals, go to work to do a good job. It's an extraordinarily confronting proposition that a whole community of people going to work to do a good job can cumulatively have a mortality rate that is 40 or 50% greater than you would expect. These are hard questions. Good hospitals monitor their HSMRs, their safety and quality measures, actively using the kind of tools that Chris provides or a variety of others, and seek to understand where performance may be falling short, and action should not stop until the clinical leaders and the board at the hospital are satisfied that the issues have been effectively dealt with. I think that sums up the challenge. That sums up the task. Hard questions pursued with vigor. It's painful, it's difficult, and I can tell you, those of you who do it will not be thanked. And the more energetic you are, if you're an epidemiologist, the shorter your career will be. But nevertheless, at the end of the day, you may feel that there's a few people walking around who have benefited from your efforts. Thank you very much.